Great. Welcome, everyone. Such a pleasure this evening to be joined at Wu University by Nora Cothran. Thank you so much for having us. The lecture that we're going to talk about today is modern MIGS around the clock control. Next slide, please. I'm your host, Dr. Carolyn Major. I'm an associate professor and the director of residency programs at the Oklahoma College of Optometry. Great. So it's such a pleasure to have our speaker here today, who upon her graduation from the University of Michigan, Dr. Cothran was commissioned as an intelligence officer in the United States Army Force. She actively participated in the global war on terror and was selected to serve as the director of intelligence for America's first combat-capable F-22 Raptor squadron. Thereafter, her contributions to national security continued as a contracted intelligence analyst for the Department of Defense. And then compelled to pursue a career in healthcare, Dr. Cothran earned her doctorate of optometry from Southern College of Optometry, then went on to complete a residency in ocular disease at Baskin Palmer Eye Institute, University of Miami Miller School of Medicine in Miami, Florida. And she currently practices at the Eye Institute of West Florida, where she specializes in the diagnosis and treatment of glaucoma and neurologic eye disease, and is a fellow of the American Academy of Optometry. So welcome, Dr. Cothran. We're so very excited to have you here with us.
Thank you. Thank you so much, Dr. Masher. These are my financial disclosures, and any financial relationships that I have been mitigated for the purposes of this exam. For the purposes of this presentation. Let's move forward here. Let's see. Here we go. All right. Oh, let's see. All right, here we go. All right, let's talk about one of my favorite subjects, glaucoma. I really want to thank Wu University for the opportunity to share something that I'm very passionate about, something that I do day in and day out, 5 days out of the week in a secondary tertiary care facility. And that's managing a disease that can sometimes feel very intimidating, can sometimes feel very disheartening, a disease that, quite frankly, up until about a decade ago, we really just didn't know that much about. And so tonight's topic is going to be on MIGS. And we'll talk about what MIGS are. We'll give a little background of glaucoma first, but tonight's topic is modern MIGS, around the clock control. And again, these are my disclosures. This is an overview of the topics we'll be talking about tonight. But let's start with me. What, folks on the call, maybe, who's this lady talking about glaucoma? What does she know about glaucoma? And where does her background come into play when it comes to, the diagnosis and management of a disease that was often thought of being, relentless and guaranteed to progress? I did a lot of training in the world of optometry, and this presentation was actually originally built during the pandemic so that I could give the majority of it. So a lot of the pictures there are from that time period. But prior to my world of optometry, I had a little bit of a different life. And instead of being Dr. Cothran, I was Lieutenant Heat Cothran. I did a lot of intelligence, threat, and analysis to protect the United States. And part of that had to do with these kind of MIGS. And so the type of MIGS that I was looking at day in and day out were on a very, very large scale. And so I find it, a little serendipitous that now I've come full circle. And now I'm looking at MIGS and managing MIGS and recommending MIGS that are on a very teeny tiny scale. So before we start talking about MIGS themselves, let's talk a little bit about glaucoma. My colleagues in the rest of the series of The Silent Thief have given you guys some excellent information. Anywhere you see a little cute star in the top left corner, anything that's purple in the slide set might be a little bit of information that might be important, maybe tied to certain types of questions from before and after the slide, but it helps you just to kind of be able to enjoy the presentation, not have to worry about not knowing the answers to certain things. Glaucoma is the leading cause of irreversible blindness in the United States and also worldwide. There's a lot of different etiologies of glaucoma, but the primary are anatomical and vascular. Well, we know that there is definitely a genetic component with a minimum of at least 28 different loci up to 168 across the entire human genome. There's no doubt in my mind that in our lifetime of practicing, there's going to be an autoimmune component. I just feel it. And ultimately, at its root, glaucoma is a neurodegeneration of cranial nerve 2. This is a disease that can be slow and steady. Some versions of it can be fast and furious, but ultimately, I explain to patients, it's like if you've got a cable that connects your TV and you've got a mouse chewing on the cable. And as he slowly chews through the cable, the more damage that's done, the more dangerous the situation gets when it comes to, being able to watch your shows. So first, let's talk at the back portion of the eye and the anatomy. Right now, we're taking a look at distribution of the nerve fiber layer. It's really important to know the structure in order to understand the functional loss. So when I'm teaching my optometry interns that rotate through my practice, I explain to them, think of the nerve fiber layer as being like a broom, and that broom has all these little fibers across it. Well, there's a division, the horizontal raphe that runs, across the horizontal meridian. And if you think about that, like taking a piece of plexiglass and shoving it right in the middle of that broom, and what that does is it kind of sets up your mind for understanding that glaucoma is usually a hemispheric type disease with defects that respect the horizontal meridian. Additionally, if you have areas of those little broom, if you start snapping up pieces of that broom or you start lighting little ends on fire and they start moving forward, you're going to get dropout of that retinal nerve fiber layer where it ultimately feeds into the optic nerve. And you will ultimately see structural loss that mimics functional loss. So oftentimes, if you see areas of the optic nerve or areas of the retinal nerve fiber layer with your own human eyes, you will actually be able to predict with pretty good accuracy, the more you manage the disease, of what you're going to see when you look at a visual field and any type of diagnostic testing that depends on the patient's input. I'm going to talk a little bit about the difference between a 24-2 and the 10-2. For those on the call, if you ever see a teardrop-shaped field, that's your traditional 24-2 with the point pointing toward the patient's nose as they look out into the world. So as we look at this would be the patient's left eye as they're looking out into the world. But the 10-2 is just as important. 10-2 is looking at the central 10 degrees of vision, and this is extremely important when it comes to patients' quality of life. And so looking at that central 10-2, for example, this patient here was a patient I saw before COVID, got lost during COVID, came in only because their vision felt like it had gone down. And in those period of time, even though the patient was relatively stable, they had a bit of non-compliance of their topical therapy. And this, they actually lost just 2 lines of vision on the Snellen chart. There's a functional loss that reflects the structural damage that's happening. And I often like to look at the nerve first and then imagine in my mind what I think the testing. I think that some of our younger practitioners out there are leaning too much into the testing and forgetting to physically evaluate, to visually evaluate the nerve. And so here you can see this notch or this area of focal neuroretinal rim thinning on the inferior portion of this nerve and on the superior portion of this nerve that matches. And so you will actually be able to predict what you're going to see on some of the testing. What is the most important diagnostic test? One of the things we have in our toolbox is something called a ganglion cell analysis. If we look at the layers of the retina and we look at the ganglion cell complex is the ganglion cell body, the dendrite, and the axon. But the ganglion cell analysis, which is a feature you can run on most of your OCTs, is looking at just the ganglion cell bodies and the dendrites, not the axons. You can actually find damage far in advance, and sometimes you can actually have up to 40% of ganglion cells lost before you have any visual field defects. So you can have patients that are having active damage that's progressing that you can quantify with testing, which you can bill for. The patient has glaucoma, and before they even lose field. So about a decade ago, a lot of docs were waiting to treat until the patient actually went from glaucoma, hemifield that test within normal limits to borderline to outside normal limits. But initiating treatment early and aggressively is extremely important. The anterior chamber possesses the area of aqueous production and also aqueous outflow. Trabecular meshwork, which is the conventional outflow, and the uveal scleral, which is our non-traditional pathway. And they ultimately together pair to make up about 100% of the outflow. So we know what glaucoma is kind of from the, anatomy and physiology. We know what glaucoma is when it comes to, what we've learned, what our testing can show us, the structural components of what are breaking down. But what is glaucoma when it comes to look at, say, our communities, our states, our country? It's estimated that 120 million patients will have glaucoma worldwide by the year 2040. 2040 is right around the corner. Of all the patients that have glaucoma, about half are walking around not even knowing that they have it. This is a huge economic burden just within the United States in and of itself. And what's the most heartbreaking to me is that there is a disproportional impact to members of our African American community, patients with poor health literacy, the unemployed, and the disabled. These are the most vulnerable members of our community, the most vulnerable members of our society. The AGS stands for American Glaucoma Society. This is primarily composed of MDs that are fellowship trained glaucoma specialists. There's about 1,500 members. However, there's about 500 to 550 ophthalmologists, general ophthalmologists that are retiring every year, leaving the workforce. There's not a blossoming of glaucoma fellowships out there. In fact, there's a shortage of glaucoma fellows. So who's going to fill this glaucoma gap? That's what I keep calling it, the glaucoma gap. We've got baby boomers getting ready to be diagnosed with glaucoma or already have it. And optometry. Optometry has to step up the plate. This is fully within our wheelhouse to be able to manage this disease. We are particularly suited for it as a profession. And now within all 50 states in the United States, not only can you actively manage and prescribe glaucoma, but you have the ability to access all types of CE to get you up to speed on it. Another way to describe glaucoma is where we've come and where we've gone and where we're going. So glaucoma used to be thought of as a pressure of just of a disease of just high eye pressure. And then in the advent of OCT, glaucoma became a lot of red disease. Anything that's red, any red wedge, any red sliver on the OCT, that's glaucoma. And now we've come to find this nice balance to realize that not all glaucoma has raised eye pressure. Not all glaucoma flags red and has red disease, and not all red flagging RNFLs are actually glaucoma, to finding an understanding of a neurodegenerative optic neuropathy, like on that very first slide I showed you, and utilizing an interventional model to manage this disease. Interventional doesn't have to mean surgical intervention. It can mean an active intervention with therapeutics or MIGS or anything that we have within our toolbox, SLT in some states for optometrists. We have a lot of options that are out there, and I think it's really important for us to understand why we want to do this. There was a glaucoma adherence and persistence survey, and what it was a retrospective review of pharmacies, and it was looking at their databases of patients that were prescribed glaucoma medication within their first year of treatment. And within that first year, over half of patients missed a refill. These are not patients that are worn down from glaucoma and follow-ups and these are patients that just got diagnosed with a visually damning, potentially progressive, potentially life-altering disease, and over half of them missed a refill. And only 10% of them reported actual consistent adherence. Now, is it because patients want to go blind? Absolutely not. I think that some aspect of it is patients not truly understanding the large-scale ramifications of not abiding by, our therapeutic or recommendations or our treatment protocols. I think another part of it is patients. Patients have a lot going on in their lives. There are a lot of things that are happening. You as a practitioner are, a 10-minute, 15, 20, 30-minute, depending on how long of your appointment, but you're a part of their day, but there's a lot that's going on in these patients' lives. I truly do think in the bottom of my heart that glaucoma patients want to do the right thing. Nobody wants to go blind. No one chooses to lead down the road to blindness if they can avoid it. And what's really sad is there was a NIH glaucoma literacy test, and even though about 86% of patients that were surveyed said glaucoma can be controlled, 50% of the patients for the IQ test said vision can be restored, which is so sad because there's a lot of times where patients will come to me and say, well, now that I've lost this vision, what can we do to bring it back? And sadly, there are no drops, lasers, or surgery that can repair the RNFL at this time. Patients are often grossly unaware of their inability to actually instill their topical medications. We've known this for years, but Ranjala and her colleagues did this very interesting study where they had patients instill a drop in a room with a table and and a mirror and good lighting, and there was a camera there. The patients knew they were being filmed, and what this did was it took out another person sitting in the room so that the person wasn't nervous, the patient wasn't anxious, and they recorded the patients putting in the drops. And about 87% of the patients were deemed to have effective instillation techniques. Well, they follow these patients 5 years out in the future. And at 5 years, 100% of the patients that were in that ineffective technique group, they all experienced disease progression, not just subclinical disease progression, but progression that actually reflected within their visual field. And the majority of those patients required additional therapy or incisional intervention. Now, were they needing additional therapy and incisional intervention because their glaucoma was controlled and it was progressing? No, they needed it because their glaucoma was not controlled, and the non-control was due to inadvertent non-compliance. So I ultimately think that patients are trying to do the best things. They're literally trying to do the best that they can. You know, bottom line, a lot of docs on this call, even if you're not interested in glaucoma, you're like, why the heck does any of this matter? Well, this is why this matters. As we look at these fields are oriented right and left eye as you are the person looking out into the world. So for the next 2 minutes, put yourself in each of these patients' shoes and think of what life is like at this point. This is a military veteran. This is somebody that dedicated their life, an entire career, to serving in the Air Force. And look at how, and I put the vision in the top because oftentimes vision is not indicative of how much field loss has happened. Sometimes it is, but ultimately, until you get into your 10-2, it's not. These are very real people. This patient is 66 years old. This is a postal worker in my neighborhood. And this is his 10-2. And yet, even through those types of fields, patients still seeing 20/80, 20/50. This is remarkable. The human brain is absolutely incredible. This is a monocular patient. Patient lost one eye due to an injury in childhood. Look at that nerve. This patient's 54 years old. VACC, 20/100. No improvement. This is the maximum level of vision that this patient will have in their lifetime. This is a science teacher. This is a patient that was completely unaware of how much vision that they had lost until they hit their mailbox multiple times going out of their own driveway. This patient's a mechanic. This is a 10-2. This patient is seeing 20/40 out of that left eye. And if you look at the field the following year, not a single degree of vision progression. Glaucoma does not have to be a progressive disease. This patient has been staying stable in time. Patient's pressure is 8, staying well below episcleral venous pressure. These are very real people. These are members of our community. And this is a patient that's in his 10-2 in his only good eye. He's 20/50. It's a patient that I asked him about disability benefits. And he goes, I didn't know I qualify for disability. He goes, I work at Burger King. And I said, what? And he said, yeah, I have to stay working at Burger King because I don't qualify for Medicare. If I don't keep my job, I lose my insurance, and I have to have my insurance so I can afford my glaucoma medications. He started out working as a cash register, ringing up, and then working as a line cook, and now he washes dishes. And myself and my team filled out his paperwork to help him get his disability benefits. So ultimately, in glaucoma, there's a lot in the toolbox. It used to just be drops followed by laser, followed by surgery. But we have a whole nother umbrella of procedures that are out there that have quickly come onto the scene and have become a really, really nice resource for my patients, for patients in your community. And these are MIGS. MIGS are known by, I made this acronym ASSET. These are assets in our arsenal. MIGS are often ab-internal approaches. They're safe. They have a swift recovery. They're efficacious. And there's very minimal tissue disruption. This is very different than a tube or a trab or a shunt or any other types of incisional glaucoma surgeries. These are under a little bit of a separate umbrella. They can be performed standalone or also in conjunction with cataract extraction. And modern MIGS actually target all aspects of aqueous production and outflow. There's a lot that's out there. This is my favorite poster from one of my favorite magazines called Glaucoma Today. You can subscribe to it, and you get a poster every year. And on the front of it, it shows all of the therapeutics that are in the clinical pipeline and all of the surgical interventions that are in the clinical pipeline that are ongoing. And you can see all these different areas of targeting of things that are already FDA approved, that are right out of the clinical pipeline, that are still, at the drawing board. But we have a lot that's out there, and that area is just blossoming. This is a little more tidier version of the anterior segment, so we can take a look at it. Aqueous is produced by the ciliary body in the pars placata, and it moves through the zonules, flushes up in and over the iris, cruises over the top of the iris into the trabecular meshwork and out the trabecular meshwork and the episcleral veins. In the world of when I was in the Air Force with the F-22, you put a little triangle, and that's where your target is. So this is a fun throwback to that. So we put a target on the trabecular meshwork because the majority of the MIGS that we're going to talk about today work within the trabecular meshwork. So let's talk about the iStent inject W. The iStent inject W is often, you'll see it seated inferior nasal. It's usually about 2 to 3 clock hours apart. It's a set of stents. My surgeons prefer to put them inferior nasal. Some surgeons like to put them temporal nasal. Just talking to your local surgeons, especially those that do cataract surgery, and finding where their preferred area is. The reason that's important is knowing where to look for them when you actually have a patient that comes back with them. But also, if you see the stents located in an area where your surgeon doesn't quite usually put them, that tells you a little bit of information about what may or may not have happened at that time of surgery. This was kind of, this is one of the later iterations of what I call the OGs of MIGS. You know, the company that created the iStent really did break into an area that was uncharted territory at the time. The Inject and the iStent Inject W came along in 2018 and 2021, respectively. And what they are is the W is a pair of heparin-coated titanium stents. So they're teeny, teeny, tiny. Patients on average got IOP reduction of about 7 millimeters of mercury, and the iStent Inject W is performed at the exact same time as cataract extraction. So if you're an optometrist that's referring your glaucoma patients out to a cataract surgeon that's just doing cataracts, I behoove you to look into your community to find out a cataract surgeon that's really embracing a lot of these MIGS to see if these might be options for your patients. Insurance will usually foot the bill of these procedures at the same time, and if the patient is already having a lens exchange, it takes that cataract surgeon just a few extra moments at the end of that procedure to potentially install a little piece of hardware that may set the patient up to reduce the amount of drops or completely eliminate the amount of drops that they need throughout their lifetime. The post-op period for this is usually 90 days, and there's really no deviation that we use within my practice when it comes to the cataract combination drops, antibiotic, steroid, NSAID. And then thereafter, I usually have the patient stay on their glaucoma medication till they come back to see me. And they know that their cataract drops are one set of drops, and then all of their glaucoma medication, whether it's 1, 2, 3, the whole drop collection, I say stay on them until you come back to me, and I'll be the one to take them away. And if you co-manage with cataract surgery, you can express that you want to be able to do that for your patient after that time period, because then you get to be the good guy. You sent the patient to someone that can take out the cataract, got them seeing better, but also will be responsible for taking them off of the drops. And I usually like to down titrate the medications thereafter until the patient settles into where their target needs to be. These little tiny little stents are only visible on gonioscopy, and they're usually about 2 to 3 hours apart, clock hours apart. The stents, they do not preclude patients from having MRI scans, and they can ultimately reduce the bottle burden. In some patients, it's temporary. In some patients, I've seen them go years after and not need any additional intervention. Some of the limitations of the iStent Inject W is currently it's only FDA approved to be done in conjunction with cataract surgery, and we're still watching some sets of long-term data to see how the IOP lowering effect happens in time. And if you look at the image on the right side, you'll see this is what your view is will be in through the gonio lens, and taking a look at the iStent Inject W. All right, there's some latest and greatest stuff in this realm of this family of products. So the iStent Infinite is very similar to the iStent Inject W, but instead of 2 stents, it's a trio, 3 heparin-coated stents. And the most important aspect about the iStent Infinite is that it's FDA approved to be done as standalone usage. So it doesn't have to be done at the same time as cataract surgery. My glaucoma surgeon has really enjoyed doing this. What it does is it saves some of the conjunctival real estate that she may need for more invasive surgeries further on down the way. It also allows her to pair this with canaloplasty, goniotomy, other types of devices that work within that within the trabecular meshwork or the area behind the trabecular meshwork to maximize the effectivity of this stent. A second nice product that's out on the market now is iDose TR. What this is travoprost, and it's a sustained release. It's a 1.8 by 0.5 millimeter. It's a 3-part titanium stent. And in the phase 2B trials, patients got an IOP reduction of about 8.3 to 8.5 millimeters of mercury at 36 months. What it is, it's a teeny tiny little implant, and it's mounted into the scleral wall. And just like a Glade plug-in that goes into your wall, there's a little air freshener, a little cartridge, and this very proprietary proprietary formulation of travoprost is slowly released into the anterior chamber to allow the patient's IOP to stay stable. It received FDA clearance just about 6 months ago around the holidays. And there's not only 2 phase 3 trials, but there's an iDose TR exchange trial, which means taking this out and putting another one back in. Looking in with the gonio lens, this is what this device would look like as you're looking into the anterior chamber. So we're going to take a journey through. This is pictures that I've taken from the back of an F-15E model, and very similar to Top Gun, the new Top Gun movie where he's going down that valley and he pops up over the canyon. We kind of did this, but this is like 20 years ago, before the cool Top Gun movie came out. So Hydrus, let's talk about this. This is actually one of my personal favorite MIGS. It can either be done temporally or nasally, depending on the surgeon's comfort. Hydrus is a 8mm trimodal nitinol stent. It was FDA approved in 2018 based on the results from the Horizon trial. Patients on average had a IOP reduction of about 7.5 millimeters of mercury. This is indicated for mild moderate POAG. In the post-op period after this, and again, it's only FDA approved to be done right now at this point with conjunction with CE, but there's no, combo drop that needs to be sustained for the long term. There's a separate steroid drop that we use with these so that we can down titrate the steroid if a patient were to have any type of inflammation over time. Documentation for you, if you're the co-managing OD, put a gonio lens on the eye. The majority of these you won't be able to see unless you actually look in with the gonio lens, and document what clock hour the stent is. The image on the bottom will actually show you the leading and the forward and the superior and the inferior edge of the stent as you're looking in with the gonio lens. A high FEMA on post-op day 1 is not uncommon. This little stent is going in right into the angle, and there can be some tearing. The trabecular meshwork is living, breathing tissue that has vascularization, and so a small amount of high FEMA is not uncommon. It clears in time, and the level of high FEMA that's there doesn't necessarily have any correlation to the actual outcome or the success of the Hydrus stent in time. And the one thing that I like about this is that the Horizon data was the largest MIGS trial to date with over 500 patients that went forward long term and compared CE alone versus CE Hydrus. So instead of looking at just this MIG and how it performed in time, they actually compared it to an age-matched cohort of patients that just had cataract surgery alone. The 5-year data set was incredibly impressive. The patients were anywhere from 20 to 30% improved in drop-free rates overall, not only just the CE, but also the CE Hydrus patients. But the patients that received the Hydrus were 60% less likely to require an incisional glaucoma surgery. This means a XEN, a tube, a shunt, or a CPC therapy, which is a laser that basically kills the ciliary body. All of those are very serious surgeries. Visual field loss was lowered by 47% versus cataract extraction alone. So this was a really nice groundbreaking paper at the time in the world of glaucoma, because we could really see what the difference was between just doing cataracts or doing cataracts with a MIG, showing that cataracts with a MIG paired together, if you have the ability, like I said, to do both at the same time, there is no downside. One of the limitations of the Hydrus at this time is right now the indication is just for mild to moderate. So if you have a patient that the chart is marked severe POAG, the insurance will sadly only foot the bill if they are mild to moderate. Now, a surgeon may see the patient and deem them that they're moderate, they're not yet severe based on other factors. And so the FDA has approved this in conjunction with CE, and right now there's a clinical trial underway for standalone use. Let's show an example of a patient that might be a good candidate for this. This patient, 73-year-old white female. She's currently on dorzolamide, timolol, Q12, both eyes, and Vyzulta at night. We tried a rho kinase inhibitor. She couldn't tolerate it due to the hyperemia. And when we first met the patient, her Tmax years ago when I inherited her was 25 to 26 millimeters of mercury. At that time, the target was set to 20. Latanoprost was initiated, and over the course of a few years, her pressure kept starting to ping pong up and down, up and down. So timolol was initiated. I usually initiate timolol QAM, but I knew that my intuition told me there was some instability. So if I think I'm going to have to put a patient on a combo drop, dorzolamide timolol, bromonidine timolol, I go ahead and dose the timolol twice daily so the patient gets used to that. And when I say, you know what, we're going to add another medication on board, but you don't have to change your routine, you just got to swap bottles, it's a lot easier for them to stay adherent in time. Patient's pressure still started rising up. So then we replaced the latanoprost with the nitric oxide and donating version of latanoprost. And when I saw the patient at the most recent visit, the pressure was 18 millimeters of mercury and 17 millimeters of mercury. You're looking at that CCT, you're thinking, okay, it's a pretty thick cornea. Does this, is 18 or 16 or 17 really that bad? So take a look at the optic nerve photos. This is when we first met this patient. I always have my interns look at the photo, see what draws your eye, take a look at the isn't rule, see if there are any areas that look a little thinner than average, and see if they match with what you think that the field should look like, or what do you think the scan should look like. Patient has classic superior and temporal thinning on the right eye and a 5 o'clock thinning over in the left eye. They've got a GCC that matches. What was concerning to me is over time, the patient's nerve was changing in shape, not the RNFL, the nerve. The RNFL did look like it was changing, but as a former data analyst, you have to actually look at the data, not just look at the colors. But when you have a nerve that's atypical, that's malinserted, every single one of her RNFLs, take a look in the top left-hand corner of each of the RNFLs, look at the shape that the computer estimated that nerve was. And in every single one, it estimated a different surface area, and therefore your information that you're getting about the retinal nerve fiber layer is just as good as where the initial demarcations are, where that computer is finding that nerve. And so I really like to teach my interns, to teach colleagues to really look at the nerve, look at the tissue, look at the visual field, look at the functionality of the person. Her baseline field had no visual field loss in the left, glaucoma hemifield test outside of normal limits in the right. Because of this amount of damage, this is when she first was treated. And in 2 years, that was when she was first treated, was even before there was damage in that one eye. There was already damage in the one eye, but in 2 years time, she developed a very significant inferior arcuate scotoma that coalesced and combined with that inferior nasal step. And she's not the best test taker. And I talked to the patient. I said, Mrs. Jones, something doesn't seem right. You just don't seem like yourself. Her husband was battling a stomach cancer. She was taking him multiple times a week across the bridge, staying at Moffitt Cancer Center. She had a lot on her plate. And once I finally found that information out, it made sense why her glaucoma seemed to progress. It wasn't because she was doing everything that she could and being 100% compliant. It's because she had other things on her plate. She was worried about her husband's life, and that may have been secondary non-compliance. So as we're seeing pressures move, as we're seeing damage happen, a lot of it has to do with compliance. So I talked to her about the fact that her cataracts are ready to go. Let's have her see my cataract surgeon and see how if he could do a stent at the same time. And right there nasally, you can see that hydrus. Hers, you can barely see the leading gleaming edge of it. Post-op day 1, status post hydrus in my patient, and she had it done in the right eye and then in the left eye as well. So she would have been post-op day 1, post-op week 1. But I put the pairs of the pressures together so that you can see that they really did correlate with one another, because we do our cataracts about a week apart. But she was at 11 and 10 millimeters of mercury. So I had her go ahead and stop the aqueous suppressant, come back a week later. So this would have been week 1, week 2 for the right and the left eye respectively. Pressures rose just a little bit up, but they stayed right around 14 millimeters of mercury. I said, okay, go ahead and replace the Vyzulta with the latanoprost. Patient was having a really hard time paying for the Vyzulta and wasn't able to get on any assistance programs. And the last time, when I recently saw her at post-op month 1, post-op week 5, she was at 15 and 13. And at that place, she's well under ages. I said, you know what, let's just stay on the latanoprost, 1 drop at night. And the patient should hopefully stay stable in time. Did we get rid of all of her drops? No. Did we significantly take the burden off of her plate as far as the disease burden, the drop burden, the time burden? Absolutely. Let's talk about a few procedures that seem kind of similar but have a lot of differences. This is the streamline. This actually can be used at any clock hour. And what this is this is an incisional goniotomy that you can do about 3 punctures across 3 clock hours. And viscoelastic, using its proprietary click pulse technology, volumes of viscoelastic are actually pushed through the TM to flush out the collector channels. Patients had average IOP reduction at 8.8 millimeters of mercury at post-op month 6. That's actually pretty nice, nice numbers. The indication is for OHTN and POAG. Patients are on topical antibiotics with usually a short steroid taper. You need to look into the angle to look for inflammation or any type of hyphema, not because you're going to see anything. There's no hardware in that device or this next device called the Omni. This is a canaloplasty with a titratable goniotomy. It can be done any hour, but what was happening was that a lot of surgeons across the United States, cataract surgeons, it was approved to be done at the same time as cataract surgery, were doing goniotomies 360. Pressure was down day one, a little bit of hyphema. Well, by the time they got back to their referring optometrist or got back into the chair of the glaucoma specialist, patient's cleft had collapsed and the patient's pressures were back up. So now we talk to some of our cataract guys and say, hey, if you want to do this, just do a few clock hours. How about inferior nasal? So in our practice, the guys and gals do inferior nasal. You know, Omni is a very nice device. It was FDA cleared in 2017. It's a canaloplasty with a goniotomy option. Average millimeter of mercury drop is about 6.8. And there's a little video here in the top right corner you'll see. And what will happen is that viscoelastic is pushed through the collector channels, Schleim's canal. And then what happens is that then that injector is retracted. And in the second video on the bottom, you can see that the goniotomy part where you're actually tearing or excising the trabecular meshwork can happen with a quick pull, 180 degrees at the time. And so what that does is it allows for a very, very unique and very patient-specific driven surgery and surgery setup. Just last year, Omni released an update called the Omni Ergo. This company listened to the surgeon saying, you know, there are some things ergonomically that we would like to have fixed. And so within a 2-year time period, some of these aspects about the Omni were changed to make it more comfortable for the surgeon. I want you to take a look at the image in the top left. We have GATT-ABIC, you know, TRAB 360, trabectome, dual blade. These are all devices made by a myriad of companies that work within the trabecular meshwork, that work to either excise the tissue, to shear the tissue, to tear the tissue, to open up the tissue, to expand the tissue. A lot of surgeons are using these off-label and angles that are closed or scarred. The indication is for primary open angle. So if areas of the angle are open, you know, they are getting, it's approved, but I've seen a lot of really nice benefit in patients that were on a lot of aqueous suppressants, and all of that scar tissue is gone by the time that I see them and I put my gonio lens back on the eye when they come back to me. The limitations of all of these procedures is that the EVP still remains the lower limit, the episcleral venous pressure, the volume at which the aqueous can be brought out by the episcleral veins away from the eye. I tell my patients, it's just like if you have a storm drain at the end of the sidewalk, the pipe that goes out and leads away from the water system, the diameter of that pipe, that is the upper limit of, or the lower limit at which you can move fluid out. And in the same way with these types of surgeries, that until you get beyond that, or you build another infrastructure to move the fluid out, your episcleral venous pressure is going to remain the lower limit. Right now, the precision study is looking Omni canaloplasty versus canaloplasty trab versus iStent. And I think that in time, you'll actually see a lot more of these studies taking different types of mechanisms of action, different types of products, and moving them forward so we can kind of get a better understanding of what's out there. The Zen, we are in the home stretch, folks. Hang in there with me. We're heading through that space. We're going to pop up like Tom Cruise and bop down into that canyon. The Zen is a nice MIG. All of these are on money, by the way. Every single MIG company puts their device on a dime, a quarter, a penny. You know, and so you can see the little Zen there. It's sitting on top of that dime. When you see Zen in the anterior chamber, it's going to be superior temporal traditionally. Doesn't mean it can't be superior nasal, but it's usually going to be superiorly. And what Zen is, it was FDA approved in 2016. It's a tiny little 6 millimeter. It's a hydrophilic gelatin stent, and what it does, I like to think of it as a controlled trabeculectomy, and it's a low-lying controlled flat bleb. For those that have been in communities with glaucoma surgeons that do a lot of trabs, you can usually look at a trab and know who the surgeon was. Everyone has their own little flavor, their own unique technique, and some you'll get these large diffuse trabs that look like chemo across the conj, but the patient's pressure is still 7. You may see patients have these big bulbous trabs, or some that have cystic fluid pockets in it, and all these different kind of shapes. And a lot of it has to do with different techniques, but also the fragility of the patient's conjunctival tissue. IOP reduction was especially impressive in this particular MIG at 9.2 millimeters of mercury at the 1-year mark. Patients on average went from about 3.5 all the way down to 1.7 bottles of medication. And I found this to be the case clinically. The nice thing about this is, of all the MIGs, this is the one MIG that has an indication for POAG, pseudoexfoliation, and also pigmentary. And this also preserves real estate. So instead of carving up the conj on the outside, or installing a tube shunt and putting in a tube shunt, then these patients seem to do very well because you still have that real estate left. This is a case of an 82-year-old white male that I've taken care of him for over a decade. I inherited him from one of my mentors, a glaucoma surgeon that retired. And this patient has been through a lot. The patient was on Simbrinza, TIDOU, and Rocklatan, QHSOU. A patient's pressure was always very, very low at 9 to 10 millimeters of mercury almost every time that I saw him. But that's not the whole story. So here's a set of optic nerve. Oh, I apologize. I just realized the patient's name is on that. I apologize for that. We'll make sure that is taken off there. But that patient's baseline optic nerve photos were from 2014. This set of photos was taken in 2017 when we took names off of the pictures and we just put their EMRs on there, numbers. But if you take a look at the nerve and take a look at the thinning that's starting to happen superiorly and inferiorly, and that vertical bow tie, if you were to look at an RNFL. And in 2022, this looks pale. This is not pallor. What this is just a newer camera that we had that has a bit of a washout that happens. But the neuroretinal rim, especially in that left eye at that 1 o'clock position, you can kind of see the slow, gradual excavation on the nerve through photos. I was seeing it with my own eyes. I was watching it with the fields different than the other patient, that every single nerve RNFL was a different shape. This was pretty consistent. This patient, his RNFL shape that the RNFL was picking up. This was a field back in 2021. He's a very, very optimistic guy. He's a Coast Guard veteran, super optimistic, always reading a new book. I always tell him, I said, you're so optimistic. You clicked 33% of the time and there wasn't even a light. What's important about these trigger happy patients that have high false positives, the field you're looking at is a gross underestimate of what their field probably looks like. And what concerned me with this patient is in 2022, even though he had low reliability due to some fixation losses, still a little bit of false positives, the field had dramatically changed to actually match what the optic nerve head structure had looked like. And so what concerned me was that the patient's pressure was always 8 and 9. I had the patient sent for a workup to check for sleep apnea. I had lab works ordered. I even sent this patient for an MRI because I was concerned about some type of rare bilateral compressive lesion because the patient was so compliant. They found an incidental meningioma schwannoma, or schwannoma and meningioma acoustically near his ear. But this was POAG that was progressing despite pressures being low and stable. And this was his 10-2. And when I saw this 10-2, this is when I said, okay, we have to do something. I talked to the patient and said, Mr. Jones, is there anything you're doing on the day that you come and see me that you don't do on the other days? And he thought about it and he said, you know what? I'm putting a Post-it note on my door the night before, so I remember to put the Simbrinza in before I leave because I don't want to get too rushed and miss. And I thought, okay, that's it. I called the pharmacy. The patient had not refilled their Simbrinza in over a year and a half. This patient, as I started talking to him, had dementia, was starting to get early onset dementia. and he was seeing the Simbrinza bottle on the counter and was for sure he was putting it in. But every time when he came in to see me, he put an alert in his phone, and he put he put a Post-it note on his door to make sure he put it in before he ran out the door, just in case that he forgot. I talked to him about getting a Zen. I thought this would be a really nice option for you, sir. Post-op day 1 after the Zen, his patient's pressure was 8 millimeters of mercury. This is not the post-op day 1. It'd be a little more hyperemic here, but this is just to show this flat, compact, very even bleb that's there. And I just said, Mr. Jones, stop all your glaucoma drops. Just stop them all. And at week 1, the patient's pressure stayed nice and controlled at 9 millimeters of mercury on no drops. Post-op month 1, we floated up a little bit. I told him, I want you to come first thing in the morning, because I wanted to see with diurnal variation where his highest pressure was. And he's starting out at 12, falling throughout the day. And I just saw him a few weeks ago, and he's still staying right between 8 to 10 with no medication on board. And the field damage has stopped at this point in time. And this is FDA on label for ab interno, but the majority of surgeons that I know are utilizing an ab externo approach. There's a gold standard pathway study that looked at a Zen, comparing it to a traditional trabeculectomy, and it showed that overall in time, Zen was non-inferior, but it also had greater comfort for the patient in time, better safety. The only limitation of this, I would say, is the post-op period and watching this patient heal, but also about half of the blebs will need reneedling at some point. So if you have a patient that's had a Zen and you're co-managing and the pressure goes up, you don't have to immediately start drops. You can just as a life jacket, but get them back to the surgeon. The surgeon can reneedle. If you're looking at this in the microscope, you may miss it if you don't know what to look for. So if you look at the image on the left, that stent is almost invisible. This is very different than the tube shunts that you're used to seeing for the Ahmed and the Bearvelt valves. I tell patients, if Barbie or doctors, if your Barbie was drinking a boba tea, this is about the size of the straw that she would be holding. Again, if you're not looking for it, you may actually miss. These are Zens. These are my patients. And you can see that the tube, you will not have a bevel on this tube. It'll be flat. And the very last MIG we're going to talk about is Durista. Durista is usually traditionally located inferiorly. It was FDA approved in March of 2020, right before the world started collapsing. This is a sustained release bimatoprost, and it's within a bioinert polymer matrix. This is the same vehicle that Ozurdex is in, so we know it's safe for the eye. It's been around for about a decade, the actual vehicle it is. It's about 1 millimeter in size, and it contains bimatoprost, 28 gauge injector. IOP reduction is very similar to a prostaglandin because it is a prostaglandin from 32 to 33 millimeters of mercury. So if a patient has a PGA on, this is a wonderful option for them because you can do a 1-for-1 swap. It can be performed in the ASC, but my surgeons like to do it in the biomicroscope. It's this patient's copay. They don't have an ASC fee, and the patient, goes immediately home. And what's nice is that this started out being a nice option for patients that had therapeutic noncompliance due to memory and dexterity, but now it's been really nice for dry eye patients that are younger, or patients that are busy, or patients that are noncompliant just because they forget. Artemis was the clinical trial that enrolled the Durista patients. They had enough Hispanic and Asian patients enrolled to actually be statistically and clinically significant, clinically relevant to me. Patients were on a variety of drops beforehand, and some even had SLT treatment. Both phakic and pseudophakic patients were included. So I'm really thankful to see that this clinical trial involved a broad range of patients, to know that regardless of what the patient's on, they might be a good candidate for this. In the post-op, we have them discontinue the prostaglandin analog the day that they have the pellet put in, and you are going to put a gonioscopy lens on to identify the location of this. Last case of the day, we're in the home stretch. 52-year-old black male referred from primary OD, family history of glaucoma with vision loss when his father was young. When I see this disparity in CCT, I get a little bit nervous with regard to what I'm going to see when I look at the optic nerve. And in this patient's eye, in this left eye, we actually see this very, very thin inferior neural retinal rim. That day in the office, IOP elevated, 26 millimeters of mercury. The angles are open. There was no dysfunction within the drain, no scarring, no PAS, no anomalies. Target set to ages started latanoprost, come back in 3 weeks. When they come back in 3 weeks, I did their RNFL and their field. And when I see field loss like this in a patient that has family history of vision loss, that is generational, that is quite young. I want to get on something early and aggressively. This patient travels for work. He's out of the state multiple times a month, traveling through airports. And when I asked him how he was doing with the latanoprost, he said, I had a hard time remembering to take it as I was bouncing around, but I got it in as much as I could. And in that, when he came back, he was at 14 millimeters of mercury with just generic latanoprost. And I said, we can either put medicine on the eye or in the eye. How do you feel about putting the medicine in the eye like a little Alka-Seltzer? It dissolves over the course of time, and your pressure can stay controlled up to 3 years, as it could wear off as early as 8 in my clinical practice, but about a year, you should be able to stay off of drops. And he said, let's do it, doc. And this is a picture here. You may not see Durysta. So it's really important that to get comfortable with the gonio lens, use it, bill for it. These are your services. We're one of the professions that grossly underbills for our services. And if you can take a look here, you can see when you're looking with the gonio lens, you see this tiny little white pellet that's hanging out there right at the anterior chamber, right at the edge of it, and right in front of the TM. And he did just great. And when he came back, his pressure was even 2 millimeters lower, lower than what he was on the generic latanoprost when he was on the bimatoprost intracameral. So, Durysta, sometimes you could see it in the anterior chamber by looking in the microscope. The shape as the vehicle erodes does not necessarily correlate with the efficacy. Durysta, this intracameral bimatoprost, it elucidates medication for approximately 3 months. However, in the Artemis 1 and 2 trials, patients remain controlled for in greater than 60% of the study participants past the year mark. So medicine's gone. You could do an AC tap in these patients at 5 months. There's not a single molecule of bimatoprost floating around, but the pressure was staying controlled. In the glaucoma community, we were thrilled, also kind of stunned. So what the heck was going on? How can you have low pressure but no medicine? Some really, really smart folks out of Duke did a nice experiment, and they started doing investigation, and they investigated 86 different extracellular matrix related genes. They treated these tissues that were with either trabecular meshwork, scleral fibroblasts, and ciliary muscle cells from both glaucomatous eyes and also non-glaucomatous eyes. And what was really interesting is that you had a genetic upregulation. In one case, over 200-fold upregulation of MMP1 and MMP10, 11, and 14, and a downregulation of some of the garbage that's kind of accumulates some in the extracellular matrix. That picture there on the right is one I took on my phone when we were online with the AGS while we were locked down. The picture on the right now is the beautiful version of that display that's in the JAMA publication that was published. The formal paper was finally published last year. But the genetic upregulation only occurred in tissue that was derived from glaucomatous eyes. MMPs are absolutely critical in the removal of extracellular matrix. And so if you think of Schlemm's canal, think of it like a tunnel, and think about the MMPs as being the street sweepers. Every hour on the hour, they go through and they clean out the garbage. Well, in patients that have glaucomatous eyes, the street sweepers are broke down, they're busted, they got flat tires, and they're just accumulating trash. They are causing more trash to accumulate. And so if you have the ability by taking a known ophthalmic molecule and putting it in a different place for in the eye versus on the eye, and you have the ability to upregulate the genetic expression of those street sweepers to keep things going, it is postulated that this is the reason why the intracameral bimatoprost is lasting much longer than the 3 months that even the company that did the clinical trial thought it was going to last. I've had patients that it's wore off as soon as 8 months, but I've had patients that had pressure controlled up to 3.5 years. And so it's a really neat, interesting mechanism of action, and the effect appears to be dose dependent. We used to have just a toolbox, a little tool bag of things to manage glaucoma with, but now we have a Craftsman tool chest. As optometrists, the number of patients that we're going to be managing that are afflicted by glaucoma is rising in time. It's not going to get any easier. It's only going to get tougher. We're going to watch our parents suffer from this. We're going to watch our friends suffer from this. Patients are being diagnosed much earlier. In my community, my referral base is the optometrist in my community, and even general ophthalmologists in our community sending me patients early. We have technology that can detect the disease early. not all these MIGS that we talked about are created equal, and we just talked about a few of them, the most common ones that you might see in your clinical practice. They're not a panacea. They're small and they're powerful, but they're invaluable against this battle for the silent thief, the overlying umbrella of what our case series is here at WooU. Understanding the MIGS landscape as an optometrist, even if you're not the person doing the procedure, you have folks in your community that are surgeons. You will know what to look in an anterior chamber. When you see something unusual, you will know what it is. You won't be surprised by it, but knowing what's in the pantry allows you to know what are options for your patient and can get you to the surgeons so that we can care for our communities and ultimately do the very best that we can by our patients and for the profession of optometry.